So this is a case of body stuffing during apprehension. This was a 16-year-old that was basically arrested. While arresting, apparently he threw something in his mouth, which was loosely packed. So generally speaking, what's the difference between this body stuffers and body packers? In body stuffers, you have a very poorly wrapped small amount of drug packet. It could be a large concentration, or the strength of the drug is different, and obviously quantity is small. And that could be oral, rectal, and vaginal concealment. As I was just talking a few minutes ago, we see a lot of these. Higher risk of packet rupture because it's really put together in a hurry, or in a situation where they weren't expected on the corner of the street or during the struggle with the police. Body packers, on the other hand, they are planned. They have, condoms or it's really a smuggling operation. So they know it very well. It's a small amount of those cases have issues, and most of it is because of the delay of extraction when they go through the customs. So in reality, 62.5%, that's what I saw in the literature, of these cases have complications. And this was one of those that we see. So it was a 16-year-old male booked in a county jail detention, was picked up by sheriff deputies and then brought to us. When he comes in, our intake nurse notifies us that there's a epigastric pain, pleuritic chest pain. He had multiple episodes of vomiting for the past 4 days. So this, again, the story is a little bit complicated because he did have an attempt of arrest a few days before that, and this was a pickup on a second attempt. So this might have been that he took it 4 days ago during the first attempt of arrest. So anyway, he comes in and he denies any past medical history. Again, over and over, he denies swallowing anything, any foreign body. So in our nurse intake, when somebody complains about chest pain, they immediately do EKG. So they did EKG and they send it to me via email. And while I was in ER, I looked at it. It looked like pericarditis. It's a young kid. So if you look at it, telltale, ST elevation, PR depression with reciprocal changes in ABR. Those are the telltale signs of the diffuse pericarditis signs on EKG. So looking at that, I told the nurse to send him to the hospital, closest hospital. So we have two facilities. One is in the middle of desert. So they went to a first hospital. The first ED did a bunch of labs. His troponin was lightly positive, according to them, but they were suspecting that he has cholecystitis. So lo and behold, I was working on the main ED of my level 1 trauma centers, and they call in for transfer. So I picked it up. I talked to the ER physicians from that ER, and I said, okay, send it to us. We'll take it. So kid was transferred to us. We did basically, we gave him fluid. We took majority of his labs for us was negative, but definitely that EKG looked suspicious. He still, multiple times I asked him, he still wouldn't say that he swallowed anything. So we put him through X-ray, and it looked very suspicious in the diaphragmatic region of the epigastric region by diaphragm. And then we did a CT scan, and the CT, we'll look at it momentarily. If you look at the CT, they read it as basically it could be a foreign body or surrounding soft tissue edema. We can't figure it out what it is. Here you see it as I pointed in. Looking at this, we don't have a pediatric GI service in our hospital, so I had to transfer him to the pediatric hospital, which is about 2 miles from us. And we'll send him there. And during the discussion with them, they basically did a esophagram, in addition to what we have done, the CT scan that we have done, and found that definitely there is a defect there. They asked the GI individual to come in. The GI specialist came in and interviewed the kid. At this point, he said that he swallowed a plastic bag 4 days before that, but he doesn't still reveal what it is inside of it. So they did a scope, and if you look at the scope right here, those were marijuana extract that was basically put in a hurry in a balloon, and that balloon basically ruptured and got, while it was stuck in a distal esophagus, the point from the bottom of the basically proximal esophageal sphincter leaking acid up was leaking all this content around and irritating his esophagus and leading to that cardiac irritation. So they basically put him IV antibiotic. They didn't find an initial diagnostic any type of issues other than major swelling in the soft tissue, and he was there for about a week. Then he was discharged, and about 3 weeks later, he had to come back again because there was a microperforation in distal esophagus that was missed on an initial diagnostic. It could have been also during the EGD that may have happened. So he developed a abscess that had to come back again, get a chest tube, thoracostomy, and wash out. They did a repeat esophagram EGD and found nothing else extracted from there. It was whatever it was a very micro perforation, so it healed. And generally speaking, the diagnostic and management strategies for esophageal foreign body is a little bit complicated. I've had quite a case, and I had to also educate my residents that you cannot get a normal CT and normal X-ray and say there is no microperforation. They have to swallow, and they have to be able to eat. So that needs actually a hospital observation. That's one of the issues. We had, after this case, we had another case that was missed, and that was also a foreign body entrapment with microperforation during removal. So really timely diagnosis is essential, because if there is a microperforation, the content of the stomach most likely usually leaks into the left chest and causes a sepsis, and that patients can be compromised. Generally speaking, for somebody who has a foreign body, we use glucagon, we use nitro, we use benzodiazepine to relax it. It's really hardly works. It's really depend on the patient and how it is. Usually, I have used actually Foley catheter, and I've used also intubation, scope to go all the way into the esophagus and look at it and push it into the stomach a couple of times in my career. But it needs, majority of them actually need a scoping and a specialist. I'm gonna stop here. I know multiple cases are there, and if there's any question that I can answer. And
I do have a question about the nitrates and calcium channel blockers, which we would use for a regular old esophageal spasm. Do you still use those for those, or are you saying that okay,
yeah, we do use it because, but what's the problem with glucagon? As soon as you give glucagon to someone IV, they want to vomit into your face. So glucagon has to be given typically with Zofran or some antiemetic, strong antiemetic, and you have to watch them closely. And then the amount of glucagon that you want to use, you probably don't have it in ER. You have to ask for it to come in. It's either 2 gram or 5 gram, so it's too much. You probably have 1 gram in your, medication list.
Great case. Interesting.
Thank you. Anyone else?
So tell me again, so I have, he was initially sent because this foreign object in his esophagus was found by a body scanner. Is that right?
No. Initially was the EKG abnormality. So he
Oh,
had a
that's right.
chest pain, nausea, vomiting, and pericarditis. He did have pericarditis, but it
Okay.
was secondary to irritation from that leak
Okay.
in the distal esophagus. So the whole process was suspicious based on the EKG, and then we send him out. The way that I set it up for our system for the past 10 years is that you do EKG, email it to me, and I'm gonna read it. So it will come in within 15 minutes. I look at it, and then I'll say if it is abnormal, need attention, or keep him till morning. We'll see him, and that's what happened. Pretty much a communication between our nurses are really well educated through our routine education program, so they pick up abnormal EKG too.
So he really didn't have any symptoms.
Other than chest pain and epigastric pain, nausea, vomiting.
Right.
Yeah.
Interesting. Thank you. Any other questions or comments? All right. If not, then we will go right into Dr. Molt, who is going to share a women's health experience with us.
All right. So I'm trying to share, but it says someone else is sharing. I think how to switch over.
Sorry, I mute myself. So I took myself off. You should be good now.
Oh, let's see. It's still not letting me do it. What I'm doing wrong.
You have to stop sharing your screen so she can share her screen.
He did. He just said he did, I thought.
Oh, it worked now. We're good.
Worked on that?
All good. Yes. All right. Okay, team. So, do you see the presenter view or the regular view? You see
Regular view.
presenter.
Go to slideshow and press play. Or do you see that in the top where the play button is with the computer screen?
Yes. This.
At the top? You see that? Or go to your left.
Left. There.
Yep, you got it. That's it.
Okay. Thank you. I'm sorry. Okay. So I'm Dr. Molt. I'm the medical director of the Roscoe Correctional Facility. It's a maximum security prison for female offenders in Indiana. We're also the intake facility for females. I was asked to give a interesting presentation surrounding women's health that could relate to the nuances of correctional health. I do want to preface this by saying I never want to be offensive to anybody. I'm going to use words like non-compliant and manipulative, and I do not mean anything negative about this patient. I truly enjoyed her. It's just challenging to describe these circumstances with other words. This is a 65-year-old African-American female, medical history significant for emphysema, hypertension, hyperlipidemia, mild iron deficiency anemia, and hepatitis C treated with Epclusa previously. Surgical history, non-contributory. She did have both hips replaced in DOC though. In social history, she was a former smoker, did have history of alcohol use, but she's been incarcerated for 10 years, so no history of that recently. She is grossly non-compliant with medications. All medications are DOT. Her albuterol inhaler was even briefly DOT due to gross misuse. She burned through an entire albuterol inhaler in 2 days. She's grossly manipulative and a high utilizer of medical services. Some examples, by what I mean to set some background, is she presented frequently for COPD exacerbations after intentionally snorting or inhaling things like salt, pepper, chemicals, various sprays, aerosol deodorant. Once in medical, she would refuse medical services and then claim that they weren't offered. Another example, when she's in RH, she would demand a breathing treatment. However, when nursing went down there, she would refuse it or refuse to leave her cell. She was also observed on camera in another incident, combining red Kool-Aid with coffee grounds in her emesis basin to look like hematemesis. And she had psychogenic polydipsia for 1 or 2 months that resolved spontaneously when she had other things to focus on. She would be observed to jug multiple glasses of water all at once and then vomit and then deny that she ever drank the water. AKA, this is a tough patient. Some background, she's referred to mental health countless times for this, probably upwards of 20 times since I've known her. Really, the patient reports she's doing fine, no mental health complaints, so really not much to do. So this patient presented in September of 2022 with asymptomatic 25-pound weight loss, which is 19% of her body weight over 6 months. She actually denied any symptoms on review of symptoms, so specifically denied nausea, vomiting, abdominal pain, just the change in weight. She reports she had a great appetite, was eating all of her meals.
Yet she does not show up in the butterfly family's role. What did you do?
Oh, there's something playing. Okay, never mind, it's done. She thought maybe it was due to her being in RH for so long without commissary access, but her custody report she was eating all of her meals every day. The provider did order a workup, including labs, CBC, CMP, TSH, A1C, UH, chest X-ray, FOBT, and weekly weights. The patient did refuse all workup labs. And for example, nursing did call RH before going down for lab draws just to make sure she would get them. She said she would, and then she refused, but she did eventually allow them. Just showed mild chronic stable anemia with a normal MCV. The provider did order some nutritional supplements while she was in RH, and she did gain 4 pounds at her 1-month follow-up. And the provider did continue the current treatment plan of weekly weights and nutritional supplements. She presented 1 month later with acute onset nausea, vomiting, alleged hematemesis, abdominal pain, and she endorsed a 3 to 4 week history of hematochezia as well. Due to her history of providing conflicting background stories, she was admitted to the infirmary for observations so that we could see if we can observe any of this. Stat labs were obtained. She now has low albumin at 2.1, was normal 2 months prior, but her hemoglobin was stable at 10.1, previously 10.5. Provider did order a stat KUB. I'm sorry for my dog in the background barking. Provider did order a stat KUB that was normal, and provider started BID, PPI, and Carafate and referred her to GI for an EG and colonoscopy. And she was discharged back to the dorm after she had no hematemesis, hematochezia, or melena during her entire 1 week infirmary admission. I actually saw her for this appointment for her 1 week infirmary follow-up. This is the first time I was seeing her for this complaint. She reported to me, quote, a period coming from her rectum. However, her FOBT was normal and negative during my exam, and she had a normal rectal exam. I did lift up her shirt to take a look at her abdomen. Her abdomen looked almost exactly like this picture. It was protuberant, it was shiny, it was distended, it was tense, and there was about a 2-inch violaceous nodule just above her umbilicus. Due to that, I did order a CT abdomen and pelvis urgently, and she actually saw GI the next day who also ordered a CT, in addition to the EGD and colonoscopy. Did anybody have any questions or thoughts or differentials so far?
Cancer.
Yeah, definitely.
Psychosomatic.
There's definitely some psychosomatic issues there for sure.
Cancer would explain weight loss, unexplained weight loss, and just about everything. So it's cancer until it's ruled out.
Definitely, yeah. Actually, the second I lifted up her shirt, it brought me back to a lecture from medical school. In the slide for a St. Mary Joseph nodule, the GI doctor said, if you ever see this on physical exam, it's advanced malignancy until proven otherwise. So, yep, once I saw that, it all made sense. So we did get the CT abdomen and pelvis that showed ascites, peritoneal carcinomatosis, diffuse lymphadenopathy, and then unfortunately, some solid ovarian masses. She did have a biopsy that week showing metastatic ovarian cancer. This is not her CT, but it showed everything that she had. So the ascites, the lesions on her peritoneum, lymphadenopathy, ovarian tumors. Treatment course, I did refer her obviously urgently to oncology, who recommended 6 cycles of chemotherapy. She did see gynec as well, who elected for debulking surgery after completing chemotherapy. She'd require weekly paracentesis, so we did place a Pleurex catheter, although unfortunately it was complicated by MRSA bacterial peritonitis. This is from the patient. She was removing the cap of the Pleurex catheter, removing dressings, touching the actual catheter, tucking it in her bra or underwear, and she was even chewing on it at one point. Eventually, she did complete chemotherapy and had successful debulking surgery, bilateral sublingual orophorectomy, and transabdominal hysterectomy as well. Her care was delayed significantly by her refusing trips. Chemotherapy was supposed to take a total of 4 months and actually took a total of 7 due to trip refusals. These were largely due to her complaints that all the officers, everyone that she's ever met, was wearing too much cologne or was wearing too much body spray, and that she couldn't go because she had emphysema. I physically myself had to go smell the vehicles and talk very closely to the transporting officers to call her bluff. When I confronted her with it, she told me she just did not want to go those days. And while she's in the infirmary for treatment.
Do you
Go
think
ahead.
any of this was, did she have metastatic disease to her brain? Did that
No, she had,
explain any of this behavior?
no, she had a normal brain CT. Believe it or not, this really truly is the patient. But yeah, she had a normal head CT. I checked it just to be safe. And while she's in the infirmary, she did assault an 80-year-old infirmary patient and threatened and harassed several others while she was admitted. Where is she now? She's actually out on parole, but she's unfortunately MIA. Transitional Health is still in contact with her. Well, still in contact with her family. The family reports she's on an alcoholic bender for several days at a time. Family reports they've tried to get police involved. They report they've taken her to various ERs for mental health evaluations, but patient isn't found to be gravely mentally ill, so she's discharged. I did recently receive a release of information to send records to a new oncologist next month, so I'm hoping she is following up. Some take-home points that I want to talk about as it pertains to corrections is burnout. This is tough, right? This is a tough patient population who, don't get me wrong, I care deeply about, but it's hard to manage all these tense situations, the manipulation, non-compliance, high frequency of personality disorders and traits can be very challenging too. And for me, a lack of perceived appreciation is tough as well. I almost never hear, Dr. Moult, you guys are doing a great job. When I do, I literally cry. I save every thank you card because there's not too much appreciation. That's tough. That's one of the hardest things for corrections for most people is just staying enthusiastic, staying diligent, and not trying to let biases influence things as well. I do think there was a teachable physical exam point, which is that Sister Mary Joseph nodule that really made me draw back to that medical school lecture. And I'm pretty sure it was the same exact picture that I used. Like that was exactly what I was looking at with the patient. I think this is a good teaching point also for the providers who saw the patient before me. Actually look at the abdomen when you're doing an abdominal exam. Don't evaluate it through the shirt because you can really learn a lot just by looking at the patient. You know, there's also a lot of poor understanding of women's health issues. I know I didn't really get into this too much, but there was actually a mock sentinel event called on this because central office, which is our DOC kind of administration, somehow got involved. And they felt that this diagnosis of ovarian cancer was missed when really she was presenting like a GI malignancy. And from when she reported weight loss to the actual biopsy was less than 2 months, which is pretty quick for corrections for me at least. Some things that also came up on the Sentinel event, central office felt that because she didn't have a PAP that year, that's why she had ovarian cancer, or that would have detected it. We all know, right? Pap smears do not detect ovarian cancer. And actually, something I was surprised to learn was bimanual exams are very, very insensitive as well, with a sensitivity of less than 5%. In addition, she aged out of those two. But something really challenging for women's health is there's no guidelines for ovarian cancer screening at all. Right, for mammograms, colonoscopies, pap smears, very clear guidelines, very well laid out. And unfortunately, with a disease that is usually so advanced by the time it's diagnosed, that's tough. And it's tough for patients to swallow too. I will say as a whole, we are ordering a lot more pelvic ultrasounds. We usually diagnose about 1 or 2 cases of ovarian cancer a year at my facility. Probably just because we're screening so much. We just never want to miss it. Let me see. Oh, this is a quote I find is very applicable to corrections, which is you can't control the wind, but you can adjust your sails. And this is how I like to view essentially fresh, hot nonsense that happens every day. Whenever I walk into the building, I don't know what's going to happen. I don't know what people are going to do. I don't know what they're going to swallow. And I can't control that, but I can adjust my attitude. So that's kind of the most helpful advice I have for correctional medicine, you know. But that's really all I had. Did anybody have any thoughts?
Thank you, Dr. Moult. It was really, you know, I lost a sister to that.
Oh, I'm so
she was
sorry
an
to hear that.
educated, she was a very educated person, and she actually took care of herself, but they still missed it. And the problem is, other than you doing a CT or ultrasound can miss it too, and on the early stages. Other than CT scan or MRI on a medium segment of it, you will still miss it. Now, do you guys are capable of doing handheld ultrasound? Do you have that capabilities, or like
So
butterflies or a small?
we could actually, the butterfly I think is at a different correctional facility, but I'm thinking about asking for it because I think we would really use it a lot.
Because you could have seen the anasarca right there, and Yeah.
Right.
Thank you so much.
Oh, no problem. Yes, I'd love to get that butterfly. I know Dr. Wilkes wanted us to have it at Rockville, so hopefully soon.
All right, any other comments, questions for Dr. Mold?
Well, I have a couple of comments. One is that this is the age-old issue that difficult patients can get sick like anybody else. And if sometimes when we're irritated about what they're saying, it just might be that they're right. And we need to look again, and we're going to find that. And the other thing is that sometimes patients, I imagine that this patient knew something was going on more than she let on. And it's interesting that she would complain about other more trivial things, but didn't bring this to your attention. It's like the woman who I will never forget, who said, "I've noticed something in my breast, but would you take a look at it?" As someone who had just been transferred to one of my jails from a prison, she took a look at the breast, and it was just this fungating mass of cancer that, of course, had been there.
That's interesting that you bring that up. I just had a new intake come to the facility last week with just that, and I was going to present on it. I have never seen anything like it in my life.
It'll get your attention, but it obviously had
Yes.
been going on for a long time. She knew it and had never shown it to anybody. And of course, nobody, even doing her physical exam, normal physical exams in prison, had never asked her to take off her top and seen it. Anyway, it's just an interesting point. That was a great presentation.
Oh, thanks. But I hope I was being respectful enough. I really appreciate this patient population. It's just tough sometimes.
It is. Thank you for the presentation. Dr. Eskew, you're up next.
Okay, so I'm gonna start by just verbalizing this, and then I'm gonna do a screen share, assuming the computer will let me do it. So Dr. Mold, if you want to end yours, you can. There you go. Okay. So I'm gonna start by giving you some symptoms here. We've got a male patient, mid-40s, who comes in with no real medical history of note. Used to smoke, but quit doing that about 10 years ago, and really doesn't even think that he has any chronic conditions at all. And he says, except I do real bad in the cold. I need an order for an extra sweater. And in fact, I even need some muffins or muffs for my hands because my hands get.
What's the salt?
Thank you. Because my hands get so cold that I just feel like my fingers are going to freeze and fall off. And so you start asking him questions about this, and you think, well, okay, sounds like this could be Raynaud's. And you show him a picture of what Raynaud's looks like, because I always find a picture's worth 1,000 words when it comes to Raynaud's. And he says, yeah, my fingers look like that when they get cold. And you say, okay, do you have trouble swallowing? If you swallow something, a bigger piece of steak, does it get stuck? Yeah, that can happen. And how do you do with if you're swallowing certain cold drinks like a iced tea? Yeah, that'll bother me too. And then he says, I feel tired all the time. I do get short of breath easily. And so this would send me, at least, down a road of potential autoimmunity, thinking about Crest syndrome, thinking about whether or not all these things are related. But I'm going to go ahead and tell you that's not the answer. Okay, that's not what I'm going at. And that's why I think this is a challenging case. So let's say you diagnosed and treated them with something along the Crest spectrum and sent them to rheumatology, and they tried a few medications, and they come back to you and they say, you know what, none of that helped. And DOC's breathing down my neck because they think I'm manipulating to get these extra blankets. And my roommate's complaining that I want the room even warmer. But they left it too cold and the air conditioner was blasting and my fingers really hurt. Now my urine is dark. And so what else could this be? So now that I've maybe got your interest a little bit, I'm going to switch here and actually do a screen share and show you what the heck we're talking about. I've only had one patient with this condition. It's quite rare. Okay, so hopefully you see my screen. So this is is it big enough for you to see it?
Maybe.
Does that
There
work?
you go. That's good.
Better. Yeah,
Better?
thanks.
Okay. Okay. So this is my outline for cold agglutinin disease. And that's what this guy had. And it can throw you off. And why would you look for it? Because it's so darn rare. But we actually did have a patient with cold agglutinin disease. And so these are the percentages of patients who have each of these symptoms. So they often are complaining of fatigue and shortness of breath. They can, fool you and look like a COPD patient with a Raynaud phenomenon really easily. And then you kind of hear about their esophageal spasms, but they really are sensitive to cold foods, much more so than other patients. And their urine can turn dark because they have both intravascular and extravascular hemolysis. So this is an autoimmune problem where they start attacking their own red cells when their blood gets too cold. So it will go into their distal extremities that are cold and start having a bad coagulation cascade, and it can cause problems proximally as well as the obvious distal problems that you could have from that. So how do you figure that out? You've got to do a direct antiglobulin test, a direct Coombs test, and then you trend all kinds of things when you're treating them. These are all different measures that hematology would use to watch for hemolytic problems, from an LDH to their total hemoglobin or bilirubin, haptoglobin, retics. And it can be challenging to treat and challenging to transport, because we were in Wyoming. Wyoming gets cold. And all your offsite appointments, at least for a lot of the year, involve navigating that cold. So it was a challenge, because even brief exposures can trigger this cascade of problems you don't want. For a long time, he was on rituximab combined with bendamustine at times. And then ultimately, his hemoglobin kept dipping too low, and he was having, fortunately for us, milder episodes while on that treatment. And then eventually we got him on sutimlimab, and he's been maintained well there. The sutimlimab data is not dramatic, because there's not a lot of people who have been researched for this particular medication yet, but he's hoping it's going to work for him long term. But his history has been one of take a medication for a year or two, only to gradually watch it become less effective and then have to pivot. So it was one of the more crazier cases that we've had come through there. And so I've got a little bit about the pathophys of it here. So bone marrow is producing an IgM that can attach to the red blood cell when it's cold. You often notice it distally. As things warm, the as this blood enters central circulation and the cold agglutinins detach from the red blood cells, the agglutination can resolve. Re-exposure reattaches the IgM again, and that can activate the complement cascade. So anyway, there you have it. It's a complicated condition, one that's easy to miss, because why in the world would you think of this? But it's in the back of my mind now that when I have somebody showing up and I start thinking CREST syndrome, I better also consider the possibility of cold agglutinin, especially if there's something abnormal on the CBC that doesn't quite make sense to me. And then I need to be ordering those additional labs that we talked about above. So that's what I had for the group.
I have a couple of questions for you. This was a prison?
Mm-hmm.
And how long was he supposed to be there?
As far as I know, he's still there. I'm not there now. This was in Wyoming.
Well, I'm just wondering if that was not a gift, that he was in prison, being able to get the health care that we all know we provide inside the walls, versus him going to a family practitioner in the community where he lived, who may never have thought of that as a diagnosis.
Yeah, and I'm not good. Don't count me as a genius. I didn't think of this. He came to me with this history, and I had to teach myself about cold agglutinin disease. He had been diagnosed, I would guess, from the records I looked at, probably 10 years prior to his incarceration. 5 to 10 years prior. And in the year prior to coming to us, he had been life flighted, I think 3 times, because the inpatient care that he needs couldn't be provided anywhere in the entire state of Wyoming. He can't have a regular blood transfusion. I forget why, but it's all quite complicated. And so when he has a problem, he really has a problem. And so I had to do a lot of reading and a lot of discussing things with hematology and coordinating his medications and monitoring his labs. So I learned a lot about it, kind of reading and talking to him. But yeah, I'm not the Dr. House for this case, so don't give me the credit.
Well, I'll still give you credit for a good case for us to talk about. But I was under the impression that he was diagnosed in the prison. And I always think of that, especially with my own patients, when something new gets diagnosed. I wonder, if they would have the wherewithal to go and get these symptoms checked out until they got to the point where, they were just overwhelming and he ended up in an ER somewhere.
Well, I told him halfway jokingly, you really shouldn't live in Wyoming, sir. If you need to get a one-way ticket to Hawaii or someplace hot. But like a lot of people, he had family or other reasons why he didn't want to do that. Yeah,
interesting. Well, thank you for sharing that. That was a to be announced topic that he kept secret even from the moderator before he gave it. So thank you. Dr. Wilkes is actually going to jump in for P.A. Meyerhofer, I hope I said his name correctly, whose wife has decided that she's going to deliver her baby in the next little while. And so he booked on us. But anyway, maybe he will be able to present something at our next session of case studies. And Dr. Wilkes, go right ahead.
Awesome. Yeah, no, they've been anxiously awaiting. I think she's almost at 41 weeks with her first baby. Gosh. So I'm sure they are so excited to not be pregnant anymore. But so we had a 37-year-old male that presented on, or 37-year-old male past medical history of just basically heartburn, no really ongoing issues, presented on July 22nd with some loss of control of bowel and bladder, also some numbness of his, I believe, left lower extremity, some loss of rectal tone. So we sent him to the emergency department, concerned that this had come on pretty suddenly over about 5 to 7 days. Sent him to the emergency department. They, as most ER doctors, were not super excited about another middle-aged male with back pain, with acute back pain. So they sent him back. So the provider, Alec, had called me the next day on the 22nd, the 23rd, and said, hey, I really think this guy is legitimate, and I really think he needs to get an MRI. I don't want to send him back to the ED because I'm afraid they'll just kick him back again. So being a basically self-insured entity, I gave a verbal approval for the approval for the MRI, told the scheduler to go ahead and call and schedule it next available. Part of the precipitous for this was my husband was able to get a same day MRI here in Boise. And so I was like, why can't we? So we got an MRI on the 24th, which showed a large disc extrusion at the L4, L5 level. So then based on having those MRI results in our hot hands, we sent him back to the emergency department. Actually, we contacted the neurosurgery's office, who requested that we send him through the emergency department so then they could get him in for surgery. So on the 25th, he was seen in the ED and went to the operating room that day. So a couple of reasons why I thought this was a great case to present is, number one, our site medical director for that facility, who's been doing corrections for over 20 years, And we were reflecting over it, and I think this is my only second case of actual quadoclinus syndrome that I have seen. It was her first case. So something that we see so many patients with acute on chronic back pain or just acute back pain. So I thought that brought out an interesting element for this case. But then also just the ability that we had to really get our patients the care that they needed in a timely fashion that you would not see in the community with insurance companies and having to deal with prior authorizations and all of those things. So that's our case presentation. Those are the points that I wanted to bring up, and I will open it up for discussion.
I've had a similar experience. I had a patient with acute on chronic low back pain, had an abnormal neuro exam, decreased rectal tone, a little bit of foot drop. And so I called for the neurosurgeon on call an hour south of the tiny town I was in. And the neurosurgeon didn't, I guess he didn't want to be bothered. He said, well, okay, fine, send him to the ER and then I'll go see him there. We sent him to the ER. The ER doc basically disagreed with the exam, sent him back. Neurosurgeon either never saw him or didn't care when he got called from the ER, I don't know. And then the guy had foot drop, and we got the MRI later. I don't know how much later it was, but it made me pretty mad.
Yeah, I actually, in working my first job out of residency, I had a patient, similar case. But I ended up putting him on steroids. I think it took 2 or 3 weeks to get him into neurosurgery. So then, of course, as soon as he gets into neurosurgery, they take him to the operating room. But yeah, it's really hard to facilitate that, and how important it is to try to build these relationships with our specialists and imaging partners so that we can.
I'm quite actually appalled because our ER policy is emergent MRI. And in the past year, we probably picked up, these are normal. I mean, disc herniation and things like that, or traumatic issues are basically a normal event. What we worried about is epidural abscess, which has been missed for so long. The highest pay for liability in our company in the past 5 years have been epidural abscess, where they missed it in the Midwest area. They wouldn't do MRI the way that you guys were explaining. We get MRI and we pick it fast right away. So I'm not sure how those ER actually survive there. I mean, this is deviation of standard of care. You should probably write a letter to the medical director of the hospital. Seriously, you need to change that culture there. That's horrible.
And it was 2 different ERs, and I haven't thought about doing that, providing some feedback to the ER. Boise is a very small medical community, and so we try to play nice, and because we really don't have many options. So
yeah, it looks like you need a Nikki there.
Part of me wonders if, I'm not totally accusing them of not being able to do an exam. I do wonder if the presentation might slightly improve based on the patient's body position briefly, even in transport. And now one person says that the neuro findings were abnormal and the next person's less impressed as a consequence. So I'm not sure if some of that's going on or not.
Philip, you can't fake foot drop. And if it happens, then it's permanent. That's the problem.
Well, that's what I think, but yeah.
Well, and let's face it, some of our colleagues in the community, when they see it's someone coming from a prison or a jail, they're less apt to jump in to help like they would, if I presented to the emergency department with my back pain that I have. And so I have found my experiences have been trying to build those relationships with the community, especially the ER providers. And sometimes that works. Sometimes they don't understand the constraints that we're under. And, we want to then be appreciative of you know, the issues that they have as well. But maybe just by meeting with them, you know, get an emergency department administrator meeting with the provider to say, and along with your HSA at the facility, to say, you know, this is what we're constrained by. We don't have MRIs, so we need to send them to you to get one. And, you know, just kind of go over those basic kind of things and start to build that rapport. Kind of not about this at all, but something else that we've experienced is actually the HIPAA law being used in our face when we try to get information about a patient that's been sent to the emergency department. I'm so tired of hearing, oh, well, HIPAA says we can't tell you. No, you clearly don't know HIPAA, because it's for providers to share information about. But anyway.
Wonderfully said. Actually, I think that's the best practice that we need to push, a communication with a what they call safety net hospital in your region. That's what we need to build. And I promote that one. It's a wonderful idea.
Well, I mean, I bring up, I'm like, would you ever tell a patient's primary care provider that you wouldn't give them information? And they're like, no. I'm like, well, what do you think I am? Some veterinarian, or like, no, I'm their PCP. Like, yeah, that we get that sometimes too.
Well, if you knew what you were doing, you'd be out not working in corrections, right? When we say we choose to work there, then they want you to go for a mental health consult.
Yeah.
Anyway, I had one more person on my list, Laura McKinnon. Are you here? I don't see your name in the list. She is the mental health director for the state of Wyoming, and she was going to talk to us about agoraphobia. And I don't want to not select her if she's here, but I don't see her name. So Dr. Keller, do you have a scenario for us?
I do. It was something actually just to talk about. I don't have any slides or something, and it kind of dovetails into what Kate just and that is, it's two things, but kind of both the same. And it's advocating for our patients when they go outside the system. So it dovetails very nicely with what Kate said. So let's, this is a made up case. But I've had this problem with my jails. You know, I'm a jail guy more than a prison guy, but I've had this problem with my jails, which is until I learned to fix it. Talk about that. I get a call from a nurse who says, you know, this 52-year-old male's having chest pain, which I do. And I said, send him to the ER. Goes to the ER, and then he comes back, and the ER note says, patient presents for right knee pain. and doesn't address chest pain at all. Well, how did that happen? Well, that happened because the way that the person that communicated why the patient was there was the patient. And the patient is there, and the doc walks in and says, why are you here? Well, my knee hurts, because maybe they isn't having chest pain now, having knee pain. So anyway, and I know that sometimes patients, especially from prisons, are supposed to go with this little piece of paper that's filled out by the nurse, and it says exactly why they're going. But I can also tell you, after having reviewed a lot of charts, is that the ER docs often do not read them, and the same problem happens. So that's number one. So how do you communicate? And I'm just talking about ER. I'm not talking about other offsites. But if you send somebody to the ER, how do we know that the communication has happened? I'm going to tell you what I did and my practitioners in the jails did, and we just came up with the idea that anytime that you're on call, or actually you could be at the jail too, but let's just say you're on call, a nurse calls and says, so-and-so is having chest pain. Okay, send them to the ER. At that moment, you yourself dial the ER where they're going. Can I talk to the doc? And then you have a doc to doc. I'm sending you a patient. His name is blah. This is why he's coming. there are a couple of advantages to doing that. One is it doesn't take very long. You think, well, that takes a long time. No, doctor to doctor calls go right through. I'm going to guess that the average length of time that you'll spend doing that is 5 minutes, less than how if you were to write it out a note and send it with you. Second, it works. And matter of fact, you can even say, please call me back once you've seen the patient. And at least half the time, not always, but at least half the time, they do call you back. And you have, once again, created a friend like Kate has. I mean, you know, the doc at the ER knows that you're, you know, don't have 3 eyes and, you know, that you're a normal guy, normal doc. Okay, so I'm going to open that one up and then I'll present part 2.
I put in the chat, we've actually had some success getting a direct admission. So, so calling like the transfer line, and asking for like the ortho doc on call or something, and being like, hey, this is what I have. Do you really feel like they need to go through the ED? So that's one thought too, is just using the right lingo and asking for it.
Yes, absolutely. Bypassing the ER is good sometimes.
I will say every time I've gone to call, do a doc in the ER, it's fabulous. They appreciate my call. They appreciate the background. It's wonderful. I even have the cell phone of a couple different ER doctors that work at our local hospital. So it's fabulous. That I need to do a better job at it, but networking does make a big difference.
Well,
Also,
yeah. One of my hard points is that I think it's time effective. I think that overall you'll spend less time by doing that than by not doing it. And the patient comes back and they didn't get what, you know, all things happen and then you have to clean up. So, all right, I'm going to go to part 2 now then. Part 2. Have you ever had this happen? And I've had this happen several times in the ER. You send someone to the ER, and even if they know correctly why the patient's going to be there, they don't do what you expected them to do when you sent the patient, like Kate. And case. So my case is a man who is has hematemesis. So he just vomited up a bunch of coffee ground and even, you know, a lot. You send him to the ER, and the ER actually admits him overnight, and they get they follow him. His hemoglobin drops, and so he had a significant bleed. And so what does he need? He needs an EGD. So they consult GI, and GI says, I don't think he needs an EGD. Just send him back. So
Send him back.
Send him back. So I guess it's a point of, first of all, if they did that, would you know it as the transferring doc? You know. And second of all, it's a matter of advocating for our patients, I guess. Would you call the GI doc and say, do your job? Or do you ever do that? Do your freaking job. Anyway, so I'm opening that up. That's happened to me several times too over my career.
yes, I don't think they realize how much work goes involved with requesting these appointments, getting them approved, getting them scheduled, arranging the custody trips too. It's a lot. I think if they understood how much goes in the background and how much that delays things, they'd be more inclined to do it. So maybe building those better relationships might help.
Well, it's like Phil's case too. It's a relationship thing, but it's also comes a time when you've got to get in their face. Just happen.
So Jeff, just from my standpoint, I started that in my residency, so I got a couple times in trouble getting into people's face. To remember who is the priority here is the patient, not me and you, and what you have to do after your work. So I think we are getting better over the years that I've seen, at least in the past 3 decades. People are calming down, that, you know, their God figure is a little bit, you know, lightening up a little bit because of the liabilities are coming in. And now they're understanding when you remind them that, hey, this patient cannot go back because of this and this, it puts us in a liability, the communication actually gets better. So yes, I do. Again, the priority for us as a physician, especially in a correctional environment, is to make sure those patients are taken care of before they come back into their dark cell, that nobody can find them for the next 7 days. So,
Right.
We had,
One other thing is, I'll just bring up, is that one thing I've seen happen is patient ping pong. You send them to the ER, they send them back. You send them back to the ER, they send them back. You send them back to the ER, they send them back. The way to interrupt that cycle is to get on the phone and say, you can't do this. We got to talk about this. You are not doing your job. You are not doing what you're supposed to do. And, you know, anyway, I don't know if any of you have ever seen that.
I get a call, you know, because I'm still in ER on both sides. So I get a call from somebody like, you know, Kate or Bethany or Philip, and I appreciate it because I'm getting a lot of information that I need about that patient. It eases up my workload and I direct my work up that direction. So yeah, I think that maybe there is sort of misunderstanding between this issue of I can't communicate with another physician. Try that, actually. It works well. You can call the charge nurse and tell, hey, I want to talk to the attending that is taking care of this, especially in a scenario where you have teaching hospitals, where a senior resident may take that phone call from that. So it does work, in my opinion.
yeah, we would do that too with mixed success, depending on where we were and depending on if they were going to quickly relay them to another ER. Because we had a lot of small towns, and one of the nurse practitioners who I worked with, she was usually covering Newcastle, which was a town of about 3,500, and her decision about which ER to send somebody to would often have to do with who answered the phone when she called, because there was usually just one person at the local one, and if she thought that DOC needed to try to bypass that one and go somewhere else, she would tell them, although obviously they couldn't always do that. But we kept a list of, you know, basically 2 pages. I had a page of consults that I thought were nice and a page of consults that were no good. And if somebody's name got on the no good list, we tried not to refer anybody to them, as, you know, as much as we could. So maybe that was a little passive aggressive of me rather than trying to have a conversation with them. But I guess one other thing I'll say, in my experience so far, most people who are duds as clinicians don't change. You know, if they had a bad attitude once, they tend to have a bad attitude every time. And if they can't document on Tuesday, they probably can't document on Thursday either. And they're probably 100 charts behind, and that's probably their MO.
I love that. I actually came up with the line that when you get your medical degree, you also get a bipolar syndrome, because everything is a white and black, nothing in the middle.
I would like to know what your criteria is for the do not use list.
Well, if we send somebody over to the ENT expecting an evaluation for a particular, you know, concerning lymph node that we think needs to be biopsied, and they come back with some, you know, discussion of how it's maybe not a problem, that's not a big deal, but oh, by the way, we spent a half hour on tinnitus and on this other stuff that wasn't directly related, then that'd be a good example. But we had certain surgeons who just always operated, others who never operated, and their patterns, you know, the outcomes weren't what we wanted, so we would try to go elsewhere. We would have other people who seemed to kick the can. Rather than taking care of it in one visit, they would generate 3 or 4. We would schedule we would do that complicated workup and schedule the procedure basically with whatever specialist we needed. And then they would show up at that office and they'd see a PA, and then they'd see an NP, and then they'd finally see the physician, and then they'd finally do the procedure. And it's like, here we are 2 months later and 4 visits later. Why didn't you just do this at the beginning? All you did was duplicate our work and overcharge. So that would get them on the list too.
And rightfully so.
Mm-hmm.
Well, we are perfect with the time. Does anyone have any other questions or comments before we adjourn for the evening? All right. Well, thank you, presenters, for sharing those really interesting case studies with us. And for the attendees, thank you for coming. And if you like this, let us know, and we'll do it, on a more frequent basis than annually, which it is right now. So stay safe, take care, and we'll see you next month.
Thank you. Have a great night.